Hello and welcome to All Coronary Physiology Cardio Webinar Series. Please subscribe to our channel to receive most recent webinars related to coronary physiology, assessment, and innovation. Thank you for watching. Thank you again for joining us today for a series All in Coronary Physiology. It's a cardio webinar series, comes to you from Opsens Medical. I'm really privileged today to be with an esteemed panel of interventional cardiologists from all over the world. Today, we're going to talk about Post-EuroPCR 2021 EMEA, focusing on Europe, Middle East, and that area. However, we have also a phenomenal speaker from Japan, and also we have audience from the US. My name is Chadi Alraies. I am a director of interventional cardiology research at Detroit Medical Center. I'm really privileged to be among this great panel. I'd like to thank Opsens Medical for sponsoring or for educational grant that they put it together for this program. So the agenda for today is physiology and STEMI. Dr. Emanuele Barbato going to speak to us about it, physiology in complex PCI and bifurcation, Dr. Hachu, and also the Opsens one-wire PCI solution with Dr. Monsignor. So with that, I just would like to have maybe a couple of slides or 3 slides about what are kind of major intakes or what my kind of major takes from EuroPCR. Going to take two minutes. The one good trial, I think it was great, is so for the left main coronary stent study, which is, I think, pertinent to physiology as well, presented by Dr. Heldick Smith. The study is looked at into the outcome of patient with provisional compared to 2-stent technique. As we know, the outcome is unknown till we have a recent study from China suggesting like DK crush is the best practice. However, the bifurcation, as we know, left main bifurcation is different phenomena than a branched bifurcation because of the large vessel, the steep angle of the takeoff, and also because of requiring a lot of vessel preparation. So the study hypothesis is comparing the provisional 1-stent compared to 2-layer DK crush or call-out strategy. And I think that the design is good, the multi-center, multiple, few hundred patients in each arm. So again, they compare provisional to systemic approach. As you see, the cohort of patients are very comparable. Stepwise approach has 1 stent, obviously, or less stent compared to the systemic dual stent approach. And then procedural flow was shorter, obviously, in the provisional, less ballooning and less radiation and contrast, and with a stent vessel. So the primary endpoint, which is a death by myocardial infarction, target vessel revascularization, and stent thrombosis, was comparable. There was no difference between 2 approaches. So whether you do provisional 1-stent or you do dual stent, doesn't matter. Or at least this is a signal for us that this is provisional does work as well. And the author kind of concluded there's a numerically for serious events in the stepwise provisional approach compared to the dual, and that there was less radiation, obviously, and less contrast. So I think this is a nice study, maybe a 1 step closer to understanding the bifurcation, especially in the left main. The other study I would like to present is the cardiac mortality in patient randomized to elective revascularization or medical therapy alone. This is a meta-analysis. This is after the ischemia trial was presented. So the author, Navarrese, kind of put all together in one meta-analysis, which I think is very pertinent. As you know, from the ischemia trial, there was a comparative or higher, better outcome in the optimal medical therapy group. So what the author did, he put together all the trials, randomized trials, observational studies, comparing medical therapy alone to revascularization plus OMT. Again, primary endpoint in terms of cardiac death was favoring revascularization, and this is on after an average follow-up of 4 years, which I think are pretty robust, especially after 4 years. So revascularization plus OMT is favorable compared to OMT alone. And this is also shown in other outcomes in terms of stent thrombosis and spontaneous myocardial infarction. So again, I would like to emphasize revascularization did show 21% relative reduction in cardiac mortality, especially after a long follow-up. However, it's very important to emphasize that these patients also were on optimal medical therapy. So this has to be kept in mind as we're stenting patient with stable ischemic heart disease. With that, I would like to thank you all, and I would like to introduce the first speaker for today, Dr. Emanuele Barbato. Dr. Barbato is an interventional cardiologist and a professor of cardiology at the Department of Advanced Biomedical Science of the University of Naples, Federico. Professor Barbato has been author for more than 300 peer-reviewed journals at all and PubMed in the field of pathophysiology of coronary flow, of the ischemia cardiomyopathy, interventional cardiology, and platelet pathophysiology. He has been member of several scientific and learning societies and member of editorial board for scientific journals. Dr. Barbato today are going to talk to us about STEMI and PFOs. Dr. Barbato, if you don't mind sharing your slides. And for the audience, please use the chat box or the Q&A box to ask questions to the audience, and I will entertain these questions at the end of the talk and also at the end of the program. Thank you so much.
Thank you very much, Chadi, for the kind introduction. Can you just confirm that you received my slides?
I do. Thank you.
Thank you again, and also for the opportunity to Opsens to share these considerations on the role of invasive coronary physiology in the patients presenting with acute coronary syndrome, ST elevation myocardial infarction with multivessel disease. This is my disclosure slide. So before starting this short overview on the current available evidences, I would be very interested and keen to have your thoughts on the current poll, actually. So do you measure this kind of invasive physiology, whatever physiology, FFR, IFR, DPR, and so on, are in patients with multivessel disease and patients with acute coronary syndromes? You know, we slightly modified the poll as compared to the one you have on the scale, but just try to express your opinion. You never measured this. You measured this only in the non-culprit lesions at the index procedure right after fixing the culprit lesion. You measured this at the stage procedure. You measured this in the culprit lesion post-stenting and in the non-culprit lesion. So if you could provide your thoughts and your opinion such that we could have some food for thoughts and take these comments for further discussion later on. So why do we discuss about the importance of invasive physiology in the context of patients with acute coronary syndrome and ST elevation myocardial infarction? We know that multivessel disease presentation is quite often in these patients, up to 50–55% of them. And when MVD is there, performing early revascularization improves clinical outcomes, more specifically improves mortality up to 1 year. These are early data, early evidences, showing that when performing revasc in MVD patients, the risk of 1 year death can be leveled down to the level of patients with single vessel disease. These data were then confirmed by this additional study showing that survival from MACE would improve when revascularizing non-culprit stenosis of non-infiltrated arteries, either within the same index procedure or staged. So as soon as you do it within the short period of time, the clinical outcome in these patients would improve. These early evidences were then more recently confirmed with more contemporary therapies by the PRAMI trial on the left and by the culprit trial on the right, both investigating on the same topic, addressing the question whether performing complete revascularization of multivessel disease patients presenting with NOSTEMI related to stenting of non-infiltrated artery, either performed at the index procedure, as it was the case of PRAMI, or pre-discharge, so within the same hospitalization, as it was the case for culprit. In both situations, we would see an improvement in clinical outcome. Please be reminded that this study were mostly guiding revascularization of non-infiltrated artery stenosis by angiographic appearance or angiographic stenosis severity, as we like to say. Complete trial, the largest trial of this series, has confirmed the same findings, even showing an improved combined cardiovascular mortality and myocardial infarction when complete revasc, so meaning with that revasc not only of the culprit artery but also stenosis that are located in non-infiltrated artery, is associated with better outcome as compared to a strategy of culprit lesion alone PCI. That is what we derive from this early study. I keep having pop up the the poll. Okay, now it's over. So we have to keep in mind, when we guide revascularization of non-culprit lesions in non-infiltrated artery, we run a systematic overestimation of the stenosis severity. These are data from 2002 showing that on the left, minimal lumen diameter measured in the same stenosis would be much larger after 1 month or so from the index procedure, much like the percent stenosis severity of non-culprit stenosis would be much lower and significantly lower. So that is the first consideration I would like to offer to you. Angiographic stenosis severity is somewhat overestimated when we apply this within the context of the index procedure as compared to a stage procedure. On the other side, we know that patients presenting with multivessel disease might have a mixed kind of stenosis severity, going from intermediate ones to more severe ones. When we correlate the functional severity of these stenosis to the angiographic stenosis severity, we realize that actually only with stenosis severity above 90%, there is a very limited risk that we would leave behind lesions that are not functionally significant. So in other words, if we keep applying angiographic guidance in the most common lesion setting, which is the one between 50 and 70%, look, up to 65% of these lesions would be functionally non-significant. In other words, we would be overdoing, we would be overstenting this stenosis. That is the first important concept. Next important message is the one pertaining the reliability of invasive coronary physiology within the context of patients with acute coronary syndrome. Is this kind of estimation reliable? Well, looking at this data coming both from hyperemic indices on the left, FFR, and non-hyperemic indices on the right, IFR, in both cases, it has been shown that whether you measure invasive physiology at the time of the index procedure or at the follow-up, you obtain roughly the same values, the same results. So it is reliable to do physiology in the non-culprit stenosis. Now we come to the available randomized trials that have not just measured invasive physiology, in this specific case FFR, but they have also implemented the invasive physiology to guide revascularization. So the study design was very much like the PRAMI and the culprit, but in this case, the guidance to indicate the performance of complete revascularization or the infiltrated artery only treatment was driven by FFR. So you see on the left, the compare acute did this strategy, applied this strategy mostly at the index procedure, the dynamic multi within a stage setting, but still within the same hospitalization. In both cases, an FFR guided revascularization strategy of non-infiltrated artery stenosis was associated with better outcome as compared to an infiltrated artery only treatment strategy. It is of last week, the publication of the recent Flower-MI trial that was addressing a slightly different question as compared to the previous two randomized trials. So in other words, Flower-MI has a similar study design as compared to the same one trial and was addressing whether the invasive functional assessment of non-infiltrated artery was superior to an angiographic guided PCI of the non-culprit lesion. So it was again FFR versus angiography of the non-culprit lesion. And as you can see, up to 12 months follow-up, there was no significant difference in terms of the composite endpoint of major adverse cardiovascular events. This trial offers actually many hints for consideration and for reflection. The first consideration we have to make is that what we were alluding to before, in patients with multivessel disease. Each time we try to apply angiographic guidance to patients with multivessel disease, there is a sizable proportion of stenosis that would be functionally non-significant. Now, this applies not just to patients with chronic coronary syndrome, to which the previous examples refer to, but also to patients with acute coronary syndrome and STEMI. So this is what we are discussing in this slide. This is the rate of FFR negative stenosis in non-culprit, non-infarct related artery. When this stenosis, when considered at least 50% in diameter stenosis severity, you see we go from 40% on the extreme left in this observational registry, 30% in pre-multi, 50% in compare acute, 44% in flower MI. Another interesting finding I offer to your consideration was the event rate that were observed in this trial. So you see, we go on the left side, you see the FFR arm. So we go from 13% to 7.8% to 5% in the invasive functional guided arm. And this is the comparator, 22%, 20%, 4%. So in other words, what is of interest is that in the flower MI, the two groups, both the FFR guided and the angio guided group, did extremely well in terms of MACE rate up to 1 year. Now, if we want to summarize in one slide all this evidence, we can say that performing complete revascularization of non-infiltrated artery, be it with angio guidance or with FFR guidance within the same procedure, is certainly better as compared to a conservative strategy based on infiltrated artery only revascularization and optimal medical therapy for non-infiltrated artery stenosis. This is true also for the stage sitting. And now what we know from flower MI that is that if you compare angio-guided PCI of non-infiltrated artery versus FFR-guided PCI, they both result in a very good outcome, favorable outcome for our patients. But perhaps we might claim that if you would apply invasive physiology in non-culprit arteries, you would perhaps implant less stents and less PCI. Why do we say this? Well, again, these are data coming from the flower MI. If you look at this slide, you see that the number of stents implanted, the number of PCIs performed in the FFR guided arm were 30% less PCI and 0.5 stent less per patient. There are some unknowns related to the FFR guidance after the conduction of flower MI. We don't know whether we would have less unnecessary stage procedure. You have to consider that what the investigators did in this specific trial, they treated the culprit lesion and they deferred to a stage procedure, not just the treatment of the non-culprit stenosis, but also the invasive functional assessment. So in a way, if they had performed the invasive functional assessment of non-culprit stenosis within the index procedure, we might have reduced the number of stage procedures. This is an unknown that is not addressed in this trial. We might have lower stage procedure related complications. Of course, if you would perform more procedure within the same hospitalization with a high antithrombotic burden, you can envisage some more complications. And we might have reduced lower hospitalization and stage procedure related costs. There is another point for you to consider, the inclusion of some stenosis with a diameter more than 90%, with a stenosis severity of more than 90%, which might have some potential diluting effects on the beneficial impact of FFR-guided PCI. Why? Because we know from dynamic pre-multi, the angiographic sub-study, that these are exactly the patients, so with pre-vessel disease with more than 90% stenosis that would not benefit from invasive functional assessment. They better do just with angio-guided PCI. Last consideration, and then I go to the end of my presentation. 1 year follow-up might be too short to assess the impact of FFR deferral because both groups are uniformly taking dual antiplatelet therapy. We know that latest drug-eluting stents are better and can reduce the short, medium-term events related to eccentric stenosis. In FAME1, death and MI were lower only at 2 years in the FFR-guided arm. And last but not least, this trial showed a sustained improved outcomes up to 15 years. These are my final considerations. If patients' conditions allow intermediate stenosis, and we can discuss about the definition of intermediate, but for sure, we would say less than 90% stenosis in the non-infiltrated artery should be best assessed with invasive physiology after primary PCI to improve MACE, not just to improve MACE, but also to reduce the number of procedures and the number of stents implanted. In case of ACS STEMI patients with multivessel disease, the availability of a workhorse like guide wire might enable an effective treatment of the culprit stenosis itself, but might also serve to reliably assess non-infiltrated stenosis in a cost-effective fashion and potentially facilitate further adoption of physiologic guidance. And with this, I want to show this last slide, the Optowire from Opsens, the sponsor of the current symposium, has the features of a workhorse-like guide wires in terms of consistency and reliability in the pressure measurements, but also in terms of consistently low drift, which is extremely important when you want to use these guide wires multiple times during a procedure, not just to assess vessels, but also to treat culprit lesions. With this, I'd like to thank you very much for your attention.
Thank you, Dr. Barbato, for your time and for excellent presentation. We just posted the first question of the poll, as you see there. When do you measure FFR and the non-infarct-related artery? Majority of them at the staged procedure. So this is even before your presentation, kind of, and this is an important message for me too. I mean, these changes that happen during acute STEMI and you do a physiology assessment can be misleading, but also it can give you an idea as well. The other question was from the audience for the flower MI. Was this cohort of patients are STEMI or NSTEMI and STEMI together?
They were STEMI patients in flower MI.
Okay, okay. And to your point, you are treating this patient with STEMI, for example. You're coming to NAMI or they are in flower. You do depth for them. You're treating them. So maybe you are changing you're taking them medically, beta blocker, ACE inhibitor. Maybe their ischemia is better. How long you wait for the stage procedure to come back to do the IFR?
Well, normally we would do that within the same hospitalization if we are convinced that the non-culprit lesions in the non-infiltrated artery deserve revascularization. We have now solid data showing, and complete trial is the one above all, that doing revascularization within the same hospitalization really improves cardiac mortality and MI. So these are hard clinical endpoints. So this, I would say the sooner, the better.
Great. We have, I think, one more question to leave it for later. The audience asking about the slides, if they're going to be available and it's recorded. Yes, these sessions are going to be recorded and going to be posted on the YouTube channel for the Opsens. I know it's phenomenal talks, and we'll work hard to provide you with the slides as well. With moving along, just for the sake of time, thank you, Dr. Barbato, again for your time. Maybe we'll have more questions for you toward the end of the program. So our next speaker is Dr. Hitoshi Matsuo. He is the Director of Department of Cardiovascular Medicine and Cardiac Catheterization Laboratory and the President of Gifu Heart Center. He is a visiting professor of cardiology at Aichi Medical University. He's also the director of a Japanese Society of Cardiovascular Intervention and Therapeutic, CVIT, the director of Japanese Society of Cardiovascular Imaging and Dynamics, JSCID, and the director of Japanese Society of Nuclear Cardiology. Dr. Matsuo, please go ahead and share your slides.
Thank you very much. It's my great pleasure to be one of the members of this wonderful symposiums. I will share the slides.
Please, go ahead.
Okay.
We see them very well.
Okay.
Complex PCI, especially focusing on the bifurcation treatment. This is a disclosure slide of me. As all of you know, pressure wire usage for the diagnosis of ischemic lesion is well validated and recognized as useful in routine clinical practice. Pressure information during and post-PCI is still controversial and not widely investigated. The reasons for that are mainly poor wire torque transmission and durability of the pressure wire compared with conventional workhorse wire, and unreliability of pressure data due to signal drift during procedures. Newly emerged optical sensor pressure wire Optowire are expected to overcomes these shortcomings. In case with bifurcative lesions, pressure measurement of jailed side branch is sometimes difficult due to inability to close side branch after stenting. Jailed pressure wire technique is a unique solution for this problem. In EuroPCR 2021, two very interesting papers about jailed pressure wire technique were presented. Dr. Rubinbler presented the reliability and safety of a jailed pressure wire in bifurcative PCI in vitro model. All he did is a comparison of PDPA of jailed compressed pressure wire by stent with free non-jailed pressure wire during each step of bifurcation stenting using a hydrodynamic in vitro tube model. By their observation, you can see close correlation between PD over PA of jailed pressure wire and that of non-jailed pressure wire, which means jailed pressure wire information is definitely reliable. Another interesting presentation is the clinical application of this technique by Dr. Christiansen from Denmark. He presented severe sick patients with reduced ejection fraction, reduced kidney function, and heart failure. After stabilization by medical therapy, patients were sent to cath lab. They found LMTD bifurcation lesion. To treat this by PCI, quick procedure with long contrast is mandatory. Therefore, they used IBUS in LAD and the pressure wire is placed in LCX. During crossover stenting from LAD to LMT, followed by POT with 4.5 mm balloon, LCX pressure was monitored by Optowire. After POT, they find pressure down at distal LCX as shown in this slide. DPR is 0.67. They showed unique observation of the pressure wire performance. Although the wire was jailed by stent, the Optowire 3 was advanced and pulled back, showing additional distal pressure drop in LCX. Based on these pressure data, they converted to culotte stenting to this bifurcation treatment. This case shows the use of pressure wire information is very useful for decision making in bifurcative lesion. Let me show you another interesting bifurcative lesion treatment case of us. The case is a 74-year-old male who has an inferior MI with severe stenosis in left anterior descending artery. Angiography showed LAD diffuse calcified bifurcative lesion and no restenosis in RCA. At first, we tried to insert the pressure wire to LAD. Wire performance was excellent, with no stress for the operator despite such kind of the severe calcified lesion. FFR before PCI was strongly positive in LAD, which is 0.54 with big step up at the bifurcative lesions. We treat this region by rotational atherectomy using 2.0 mm burr, like this. After rotablation, we can see a good debulking at the LAD lesion. After rotablator, Optowire is again recrossed to diagonal branch. Thereafter, predilatation with NSE balloon was performed. 3.0 by 33 mm giant stent is deployed like this. And finally, we can get a very beautiful result like this. During main branch balloon occlusion and deflation, coronary occlusion pressure as well as FFR during reactive hyperemia can be monitored in diagonal branch. In this case, you can see PDPA after balloon dilatation is 0.90, which is supposed to have the during maximum hyperemia, it is FFR. And we reconfirm the value of FFR by injection of nicorangel, and it's completely same as the balloon hyperemia. FFR pullback curve of gel side branch can be obtained without no stress. In this case, FFR of side branch is negative 0.89, which means no need for additional intervention to diagonal branch. The final drift of this case is only 1 millimercury. Let me show our data about the feasibility and safety of gelled pressure wire technique. This table shows the safety of the gelled pressure wire technique in consecutive 51 patients. No complications occurred associated with the gelled pressure wire technique of the side branch, and the FFR was successfully measured in all 100% cases. The resistance of the gelled wire pullback was considered to be smooth in 90%, moderate in 8%, and severe frictions operator fail was only 2% of the lesions. Final drift was observed in only 4% of the cases. This table shows the feasibility of the gelled pressure wire technique. Discrepancies between angiographical and FFR findings were observed in 25 lesions, which is 49%. 47% of side branch lesions were deferred despite greater than 50% angiographical stenosis, whereas 2.0% side branch lesions underwent additional final kissing balloon dilatation even without angiographical significant stenosis. The success rate of recrossing of the stent into side branch for final kissing balloon dilatation was 100%. So ladies and gentlemen, this is a conclusion slide. So Optowire gelled pressure wire technique for bifurcation PCI is not only determines the indication of main branch and side branch lesions, lesion-based assessment for the justification of final kissing balloon is possible in all of the lesions. Make easy to judge necessity of strato opening of side branch after main vessel stenting. And it can omit unnecessary final kissing balloon and may be able to make the patient prognosis better. We still need outcome data of this strategy.
Thank you very much.
Thank you, Dr. Matsuo. This is a phenomenal presentation, especially the technique you
For your attention.
showed. Yeah, you are welcome. Thank you. And we have a poll coming up. What is your approach in bifurcation complex PCI? We have a few minutes. I would like to ask the panel, what is your approach for bifurcation? Let's start with like a branch, diagonal OM or PDA approach for physiology and assessment. Would start with Dr. Matsuo.
Yeah, thank you, Chadi. For myself, I use the technique from what we have shown with the jail FFR wire. I think with the Opsens Optowire, it's very safe, and we have a very nice analysis of the physiology of what happened in the side branch. And sometimes we are always it's always difficult to appreciate when we have a very tight short stenosis just at the origin of the diagonal of the PDA branch. And with the solution, the Optowire, J wire, for me, it's very safe and very interesting to perform another approach to the bifurcation, and is it to be necessary to implant a second stent? in our center, we like the sequence. We implant the stent in the main branch. We do the pot. We open the side branch, and we do a report after that. Of course, except in left main, because in left main it's totally different. But for simple bifurcation with a circ and marginal, obtuse marginal, or ADD and diagonal branch, it's our favorite strategy.
Thank you. Yeah, perfect. Dr. Barbato, what's your approach for bifurcation?
Well, I think I do not use enough physiology to assess side branches. Why? Because I'm not always confident on the ability of my pressure wire to cross the stent struts, whether the wire would dissect the ostium of the side branch itself. So I stay rather conservative when I see preserved flow in the side branch, and when it goes of a side branch of limited myocardial distribution. If it goes over an important bifurcation with two daughter branches serving massive myocardial amount, then I want the result to be perfect, and I make liberal use of physiology in that case. But I must be honest with you, with smallish side branches, I don't open the wire. Also because I'm not confident with the ability of the wire to easily cross and recross the side branches.
So, Dr. Barbato, you were talking about recrossing. You did provisional to the LAD. You want to recross to the diagonal. You're questioning
Correct.
the ability of the wire if to go back and if this reading going to be reliable and
No,
provide
I unfortunately I do not have currently available Optowire in my cath lab. So I mean, with the wire I have, and I will not disclose which brand it is.
Absolutely.
That's why I'm very interested in seeing the data from Dr. Matsuo. That is quite reassuring. He can jail the pressure wire without problem, in cross and recross. So I'm just learning from Dr. Matsuo experience, and I'm very interested in that.
Dr. Matsuo, you showed us the data, phenomenal data there about jailing the wire. I never seen this before.
Oh, really? Yes. Please try that. Yeah. Optowire 3 is a very, very easy to do. And, recrossing of the pressure wire to the jail or main branch stent strut, it is sometimes difficult. For example, if you think about the DK Crash 4 study, which, randomized trial comparing the FFR guide arm and angio guide bifurcated lesion treatment. About 10% of the lesion pressure wire doesn't cross the strut of the main branch stent. That means, however, by using this jailed pressure wire technique, we can get the information of the physiology in 100% of the patient. This is a very good news, and maybe this may some kind of the good informations for such kind of the complex interventions.
Dr. Mansigo, you have a comment?
No, I totally agree, but be careful only with the Optowire generation, because with the other wire, pressure wire, it's not the same.
You mean in terms of jailing, you might shear the wire?
Yeah, yes.
Okay, awesome.
Thank you very much. If I may intervene, I thank you very much, Jacques, because having seen the data from Dr. Matsuo, I would be encouraged to do that with my pressure wire. But it's good that you. It's not an Optowire, so I should be careful. Great.
Yeah.
Thank you very much.
That's great.
Yes.
Yeah.
We have to be careful, especially in the situation of the severe calcified region, and we have to avoid this technique when we sandwich the wire with two stents. I mean, sandwich by metal and metal. It's I think we had better to avoid such kind of situations.
And it looks like you showed us in your data. I mean, even when you pull back the wire, there was majority of them that has no resistance. Only few has more friction than usual.
Right.
And that depends how many layer you did, how many post-dilatation you did, and how much calcification there on the artery.
Yes, that's right.
Yeah, perfect. now let's move on to our next speaker, Jack Montague. Dr. Montague is interventional cardiologist and head of the Cardiovascular Institute of the GHM in Grenoble, France, with more than 150 written and oral presentation and publication. We really appreciate having you today, Dr. Montague. I mean, and the panel. When it is one of the most attended webinar, this is one of the most engaged webinar we had so far, because that speaks to the challenge of the the complicated anatomy we're seeing more and more now, more surgical turn down, bifurcation, calcification, and also you need to have a reliable physiology assessment to understand this cohort of patients. Dr. Montague, please go ahead and share your slides.
Okay, thank you, Chadi. Welcome, everybody. It's a great pleasure, of course, and welcome to the third part of this post-EuroPCR webinar dedicated to the coronary physiology. It's my pleasure to share with you Opsens wire skills, our routine physiology wire in our cath lab. I propose you to guide this presentation around a STEMI stage clinical case using a single Optowire. Trying to advance. Okay, I have no conflict of interest. The case is a 64 years old man with an acute MI admitted very early for with the coronary angiogram show 3 vessel disease with 2 culprit lesions treated immediately. You see there is a very tight stenosis on the right coronary artery and on the distal circ, and we implant stent on the both lesion with succeed. And the patient, 10 days after, we decide to schedule a stage physiology guided revascularization on ADD and circ, proximal circ, using a single Optowire from Opsens. You can appreciate the lesion. There is a bifurcated lesion on the proximal circ, and there is a lesion on the mid ALD, and also a very tight and not very significant stenosis on the proximal ALD. And so we decide to use a single pressure wire used to assess all the lesion and to treat, of course, this lesion. First of all, keep in mind that Optowire platform is really a second generation of pressure wire with the particularity to be a fiber optic tool. So when we compare to the piezoelectric pressure wire, its design is a concentric design without electrical wires. So it's a spiral cut in stainless steel, gives high flexibility, high support, as we have with usual wire. And the second point is it's a nitinol core that offers high torqueability, flexibility, and it's very easy to advance in very tortuous vessel with this concentric design. The safety of this wire is explained by a very low tip load. You see 0 gram 660. It's around what we have with the BMW. And there is a great difference with the Abbott system. And on the left side, you see the comparison to the BMW and all the pressure wire available in France. And you see that we have with the Optowire nearly the same to the BMW wire. So to summarize, this platform gives a concentric spinning, so you can advance very gently in very tortuous vessel. You have a very higher torque response with the nitinol core, and with the low tip load, of course, you are very, very safe. on this video, you can appreciate that shaping the spring tip is very, very easy, very common, and available since few months in France. The third version of Optowire, the Optowire 3, proposes for us several advantages. With a shorter string tip, distal lesions on tortuous vessel are more suitable, and a more robust proximal shaft allows a better support with less kinking, because one of the disadvantages of this pressure wire is sometimes there's a kinking of the wire, especially when you treat several lesions. Another great advantage is to use an optical signal with a light perfectly stable and which does not degrade even for long periods use. When you want to assess several lesions, as we try to do in our case, of course, the procedure is long, and if you have a degradation of the signal, that's worse. So with the Optowire, it's very, very nice. Very easy also to disconnect the system. You see on this slide, it's very easy to disconnect, allowing to navigate in tortuous vessel, because you have like a workhouse wire, and to reconnect. And what is really very important, is when you reconnect the system, you have not necessary to equalization need. So it's a great advantage of the system. You see on the video, I disconnect the system, and I'm going to do an easy navigation. First, we decide to navigate to the obtuse marginal. You see the progression of the wire is very easy on this tortuous vessel with two branches. And we know also that one of the pressure wire limits is the drift. With the Optowire and with the Optowire 3, we have demonstrated the lowest drift on the market. This is very important. This point is really important when we decide to assess several lesions during the same step and with the same wire. So you see a great difference between the Optowire and the other wires available also. Close by FFR evaluation, we can assess diastolic physiology part with DPR, and we have shown on more than 1,000 analyses that Opsens DPR has a very nice correlation with the FFR, probably around 80% of case, and also an excellent correlation with the IFR, nearly 100% of case. So it's very safe to use FFR evaluation, DPR evaluation, DPR pullback, and I'm going to show you that coming back to the case. So first, we decide to do FFR on the circ through obtuse marginal with a positive FFR 0.773, and we decide to treat with the drug-eluting stent the bifurcation with the pod side report with a very nice results. After that, we also the same wire, of course, we assess the LED lesion with the DPR, and the DPR assessment was very significant, 0.50, so it was very positive, a large anterior ischemia, and we decide to implant first a stent on the mid-LED because the lesion was really significant. And after that, we decide to do the pullback assessment to evaluate the proximal LED. And you are going to see that the drop appears just when the sensor was just at the ostium of the LED, and this is in favor of significant also proximal LED lesion. So you see the jump was here just at the ostium of the LED, and we decide to implant a third stent to obtain this nice result. And after that, we decide to use the DPR final assessment, always with the same wire. And you see we have a nice result because the DPR was negative 0.92. So in conclusion, with this case, we show that it's possible to treat, to evaluate and to treat a patient with a multi-vessel disease with a single pressure wire. The Opsens technology used is very fantastic because the wire is really the workhouse as usual. In routine, we use a cyan blue wire, and you see we have this, with the same wire without any drift. We can do a pre-PCI assessment with FF4 DPR or DPR pullback. Several advantages of this single wire, and after that, after the end of the procedure, we can assess our result. And I think it's also an excellent thing to assess after the PCI our technique. So thank you very much, and open to the discussion probably.
Thank you so much, Dr. Matsuo. We have a poll coming up. What is the main advantage you need a physiology wire to meet in your complex multivessel coronary artery disease cases? Please go ahead and pull your answers. Phenomenal talk, Dr. Matsuo. Again, illustrate the importance of having reliable and important wire that give you consistent reading even after doing multiple inflation, ballooning, stenting on the same physiology wire.
Yeah.
A question comes in terms of, I think you already answered, but do you need, after you redisconnect or after you finished your case, do you need to re-equalize or normalize again to measure post-PCI?
It's not necessary with this wire, but be careful. When you finish your procedure, you have to verify that you have no drift just at the end of the procedure. And what we did in the case after the LED evaluation, after stenting, we pull back the wire and we be sure that we have no drift for only 1 millimeter. It's negligible.
So the answer is it's not necessary, but also as you're pulling back, make sure you don't have a big drift. If that's a drift, then normalize it is major drift. Otherwise, leave it alone. Yeah.
Absolutely. Yeah.
Other question about recrossing into the side branch. I think we talked about it briefly. Dr. Matsuo, I mean, again, I would like to pick your brain on side branch or bifurcation IFR. What's your practice? How often do you do it? And what is your protocol? If you want to unmute yourself. We cannot hear you, Dr.
Okay.
Perfect.
Okay. Can you hear? Okay.
Yeah.
So recently we prefer to use the jailed side branch technique rather than the recrossing recrossing technique, because I mentioned earlier, it's a very easier and faster, and it reduces the dose of the contrast, I believe, and the procedure time itself. Therefore, we usually, it is very, of course, the size of the side branch is too large size side branch. We usually use such kind of the technique.
Yeah, so at least you change your practice completely into not recrossing. You are jailing and finishing your work and going back. Nice. Okay, so that's a nice tip. So if you have the Optowire, that's a new approach, and it's a safe, reliable, and wouldn't shear on you when you're pulling back.
That's right.
Yeah. a few comments. I would like just to pick the brain. We have 5 minutes on your left main bifurcation lesions. What's your practice in terms of physiology in patient with stable ischemic heart disease? We can start with Dr. Barbato.
Yes, I think if there is an anatomic setting that really deserves all our attention in terms of adjunctive diagnostic tools, it is the left main stenosis, especially because its location always offers some ambiguity in assessing the angiographic stenosis severity. So when we have any doubt, like for example, we do not readily find the anatomic reasons for patients complain, we have pressure dumping, we have some sort of tapering, then my threshold would be to open up a pressure wire and measure the left main. And sometimes I'm surprised because given the large area at risk, even mild left main stenosis at the angiogram might result in a functional significant lesion. And you find this out very clearly when you do your pullback. You use hyperemia, you do your pullback, you see nice step up at the level of the left main, and that tells you a lot. And based on that, then you can plan your strategy, decide to use IVUS to guide PCI itself. But it's always good practice to do also invasive functional assessment at the end after stenting, because then you measure also the functional result of your revascularization. So that is what I normally do. I do my stenting. I tend to use very commonly intravascular imaging guidance to decide the stent length, stent size, and so forth. And then I will end up again with invasive physiology in both LAD and circumference.
Matsuo, what's your comment on the left main bifurcation physiology?
So in our routine practice, we use both physiology and imaging. And to define the ischemic burden, as Professor Barbato mentioned, as for the left main disease, there are many frequency of the reverse mismatch cases, which shows the angiographically mild but physiologically significant disease. We can encounter several cases. Therefore, I think physiology is mandatory for doing such kind of the intervention. And so we apply the physiology before intervention to find the optimal place to put the stent. And during the procedure, I don't have, because as for the left main bifurcations, we usually open the strat regardless of the result of the physiology. So, and the final confirmation to improve the physiological result, we use a pressure wire. So as for the stent optimizations, we rely on the imaging.
Imaging, right. Yeah, and as presented in the earlier in the EuroPCR trial about comparing provisional compared to dual stenting, this is where physiology and imaging are going to be imperative. Like it's very critical to do as much physiology post as well as imaging for optimization, especially if you have a single stent. But then you use your physiology to make sure the side branch, which is in this case either a circ or it's a left LAD, is not compromised. Great. Final comments, Dr. Monsigu, about the presence. We have this question all the time. The donor vessel for a CTO, how do you approach the physiology of that vessel?
Well, generally, first of all, when we decide to perform a CTO, we have the proof that we have viability on the landing zone, and we have also ischemic lesions. So I think the place of the physiology evaluation after CTO, I think it's really, really limited. And in our center, we don't appreciate the result of CTO with functional physiology. No, not in routine.
Routine. Dr. Barbato, any comments on CTO donor IFR of the donor vessel?
It's as you say, a recurrent question. I can tell you most of the times doesn't matter. What I mean with that is that you can reliably measure the intermediate stenosis in the donor vessel because it goes over normally an intermediate lesion on the LAD that is reperfusing an occluded right. That's the most common scenario. You might have some difference though, in case your donor vessel would give collateral to a massive LAD, for example. In that case, you might see some difference. But let's say that would be more of an issue in the ruling out power of the technique. Let's say if FFR is negative, then you might have, after the opening of the CTO, 3-4 millimeters mercury change in the donor vessel. But when FFR is already positive in the donor vessel, then and massively positive, you don't find major changes after reopening the CTO.
Awesome. Well, we are at the top of our 1 or 2 minutes after. I would like to thank our speaker for a phenomenal program. I'd like to thank Michele from Europe, Chantal for putting this together and helping us marketing, and for sure to our speakers for putting all the efforts and to educate us more about physiology, especially in critical cases such as bifurcation, jailing the wire, as well as in STEMI. Thank you so much for tuning in. Thanks for all the questions to the panel, to the audience, and for your engagement, and for our attendees. And special thanks to our speakers. Hopefully, we're going to see you soon in person in one of the meetings. And please be safe.